I get a chance to speak with a lot of medical professionals here on ESPN West Palm tonight, and one of the things I often hear is that you can replace a hip, you can replace knees, you can replace shoulders. The one thing that you can't replace is your back. Cyrus Wittig here with you on ESPN West Palm tonight, and as someone who has suffered back pain, back problems for more than a decade now, I know that fact all too well, and that's one of the reasons why I'm so excited to talk with our next guest here on ESPN 106.3. He is Dr. Anthony Giuffrida from the Cantor Spine Center at the Paley Orthopedic and Spine Institute in West Palm Beach and Fort Lauderdale. Dr. Giuffrida is board certified and fellowship trained in interventional spine and sports medicine, and his practice is dedicated to the treatment of spine and sports-related pain. Dr. Giuffrida brings the highest level of expertise in non-surgical treatments designed to improve his patients' quality of life by alleviating pain and avoiding both surgery and long-term addictive medication. So, Dr. Giuffrida, again, thanks for being here on ESPN West Palm tonight. I figured, we'd cover a few injuries in pro sports and then talk about how they relate back to your practice, again, at the Cantor Spine Center and Paley Orthopedic. So we'll start in the NBA with the Golden State Warriors power forward Draymond Green, who reportedly suffered herniated discs in his back, and which also affected his sciatica nerve. Green received treatment and went on to play 85 games this season. Dr. Giuffrida, what are the common signs and symptoms of a herniated disc and sciatic pain?
So I think that's a great question. Herniated disc in the lumbar spine is the most common injury you're going to have in the lumbar spine in athletes. Basically, the signs and symptoms you're going to see, it might start with a little bit of back pain, but usually it's a lot of leg pain. So you'll have this pain that starts kind of in the left or right portion of the lower back, and then it'll go down through your buttocks, through the back of your leg, all the way down to the foot sometimes when it can be really severe. Usually caused by a herniation at the L5-S1 disc. And what happens, the herniation itself can hurt and can cause back pain. What actually happens is it causes compression on the nerve root that's exiting at that level. The compression is what causes pain, weakness, sharpness, burning. But also the disc itself, I explain to patients, is kind of like jalapeno sauce on that nerve. So there's a lot of inflammation that comes from that disc and really irritates that disc. So even if there isn't total mechanical compression, you have a lot of irritation from the inflammation, and that can really cause some searing, burning pain to the point where you almost can't walk, let alone play basketball.
Dr. Giuffrida, we're going to cover a lot of different back and spine issues, but one thing I'm curious about is that, whenever the average Joe or Jane has a back injury, the first thought, or I feel like the first thought, is always herniated disc. Is there a reason why that's sort of become the armchair diagnosis when a lot of times it's not a herniated disc? It's a completely different condition.
Yeah, it's definitely become a lay term. There's different types of disc issues. We've all heard of disc bulges, disc herniations. There's even disc extrusions. These are all a little different, but for some reason, disc herniation has really been picked up by the general public when you have a disc problem in the back. If you're having pain shooting down your leg in any manner at all, you should definitely get that checked out. When the nerves aren't happy, they're going to let you know, and that's how they're going to let you know. And the one thing you don't want is the nerve to start dying. So pain is one thing, but when you start having weakness, it means the nerve is dying, and the muscle itself is losing its signal from that nerve. And without this signal to that muscle, the muscle will start dying as well as the nerve dies. So that's definitely an issue. You want to get decompression off that nerve so it doesn't die. If you're having some back pain, usually disc herniations don't cause a lot of back pain. Usually that's from just more arthritis of some of the joints in the back. So I always tell people, whoever created the spine created the back, but a lot of important things in a really small area. So you have your spinal cord, your spinal nerves, you have your facet joints, and you have all the other disc in the area as well. And a lot of those things can cause different problems. Usually back pain itself, though, isn't from the actual herniation. It's either from the inflammation inside the disc or on the end plates, or it could be from the facet joints, or even just muscle spasms sometimes. But it's always good to get it checked out, maybe see a physical therapist, see if that can help, get some imaging, but have a doctor look at it, especially if it's going down the leg. That's something you don't want to just screw around with.
Here with Dr. Anthony Giuffrida from the Cantor Spine Center at the Paley Orthopedic and Spine Institute in West Palm Beach and Fort Lauderdale. And Dr. Giuffrida, I want to switch over to hockey just for a second to stay on the topic of herniated discs. because after the series loss to the Florida Panthers, the Bruins center and team captain Patrice Bergeron revealed that he had been playing with a herniated disc. Dr. Giuffrida, how do you provide interventional spine and pain management for a herniated disc, as well as the sciatic pain that we talked about earlier?
Yeah, I always think that's amazing when you hear about what hockey players are playing with during the playoffs. Some of these guys, I remember one guy was playing with some fractures in his leg, and they're playing, and you don't even notice it when they're on the ice, and then they come off and they can't even walk. For herniated discs like that, with a lot of athletes, you can do a nice epidural. It'll give them some immediate relief. Really get some numbing medication in there that'll calm down the nerve immediately, and then get some steroids in there to keep the inflammation down. And that should work. In high-level athletes, listen, that inflammation may come back quickly because they're using it so much, so they might need an epidural every now and then, every 2 weeks during the season. In a normal, non-NHL player like myself or yourself, an epidural will usually last a lot longer because it takes longer for us to build up that inflammation again. So same principle, we can do that and really get 3 to 6 months relief from an epidural that'll really kind of clean out that area. Patients always ask me, will the epidural cure the disc herniation? It won't cure it. It won't get rid of it, but your body can. Your body can actually eat away that disc herniation. It doesn't push it back in. I tell people the toothpaste is already out of the tube. You're not pushing it back in, but your body has macrophages and other elements inside there that can clean out that disc and actually take that pressure off the nerve. I've had some college volleyball player, for instance, that comes to mind. She had a huge disc herniation at L5-S1. We got a follow-up MRI 6 months later. We did a few epidurals. It was almost completely gone. And I didn't go in and take it out. The body eats it away, kind of seals off that disc where the herniation came out of, and the patient was doing great. So there is chance for you to heal yourself. The epidural is to make it so that you're not in pain while you're healing it. But a lot of these people don't need surgery in order to really cure that issue.
Going back over to the NBA, it was reported that Brooklyn Nets forward Ben Simmons did have one of those epidural treatments that Dr. Giuffrida mentioned. He had it for back pain. And Dr. Giuffrida, besides herniated discs and sciatic pain care, what are some of the non-surgical and non-invasive treatment options that you offer for back pain?
Yeah, so epidurals are great. They kind of get rid of that inflammation, that jalapeno sauce I was talking about that irritates all the nerves. They, one, wash it out just with a mass effect with the fluid, and then two, we leave steroid behind there, and steroids are extremely anti-inflammatory. So they really calm down all that heat, that I call it, that's coming from that disc. But there's a lot of other issues that can cause back pain and a lot of other minimally invasive processes. I always say I work with some excellent surgeons at the Paley Institute and the Cantor Spine Center, and my job is to keep people from needing surgery, especially young people that are athletic or that active, because once you have back surgery, you can't take that back. You have hip surgery, okay, you can have a hip replacement. A hip replacement do really well. Knee surgery, you can have knee replacement. They do really well. There's no back replacement. You're taking this back with you. So once you have back surgery, you better need that back surgery. So we do everything we can in order to not have that done. Some of the minimally invasive stuff we do, we have some microdiscectomies, we have some procedures where we can kind of just clean out the stenosis instead of going in and totally taking out any parts. And we also have some things called ablations where we can burn some nerves that are telling you have pain. You don't need to know that you're having that pain. The arthritis is there, the inflammation is there. Calm down the inflammation, get rid of the pain. That actually helps the patient because then they're able to do their own therapy a little bit better, and their muscles of their back can retake over to stabilize the spine. So there's a lot out there that we can do in the world of interventional spine before needing surgery. And that's our goal, is to keep you from needing a big, major back surgery.
Again, here on ESPN 106.3 with Dr. Anthony Giuffrida from the Cantor Spine Center at the Paley Orthopedic and Spine Institute. And Dr. Giuffrida, just staying on Ben Simmons, he was also reported to have a microdiscectomy surgery and now a nerve impingement ailment. Could you just explain the nerve impingement and also how you would provide non-surgical treatment, again, for the nerve impingement?
Yeah, so nerve impingement is really when there's mechanical pressure on that nerve. The disc itself, or maybe an overgrown facet joint, usually in a young person it's the disc itself, is pushing directly on that nerve, almost to the point where it can't get free. Your nerves move in your back. We all look at MRIs, and that's a static image. That's what you're not moving. But your nerve actually slide through the holes in your back as we're moving our leg, as we're moving our back. When a nerve gets impinged or entrapped, it really can't move that much, and when you try to move that nerve, it's going to be severely painful. For those patients, they will probably need some sort of decompression. Now, once again, like we talked about before, we want that decompression to be as minimally invasive as possible. So there are some new procedures out there, like microdiscectomies, that are getting even smaller and smaller, where we can almost do it through the size of a pencil. A little tube the size of a pencil, we go in a really micro grasper and pull out that disc material that is pushing on the nerve, just to clean out that area around the nerve to try not to do any other damage to the spine, spinal cord, or the surrounding area.
Dr. Giuffrida, before we switch over to some MLB-related questions, I know you played college baseball, so I have to ask, where'd you play your college ball?
So I played Division III at Wilkes University.
Okay.
As we say, the Wilkes University, because, we did go to the College World Series our junior year. I was a relief pitcher, had a lot of fun.
Doctor, as a fellow former D3 athlete, I can definitely appreciate that. So, again, talking baseball, and a couple of years ago, one of the most liked, most accomplished, most respected New York athletes, especially, this was New York Mets third baseman David Wright. He retired from baseball back in 2018 due to spinal stenosis. And I know, Dr. Giuffrida, that spinal stenosis is also a specialty of yours. So, again, would you mind just explaining spinal stenosis and, again, how you treat this condition?
Yeah, so I'm actually a huge Mets fan as well. I mean, David Wright, have his autograph, met him a few times. I grew up in Binghamton, New York, watched him come up through the farm system. And, I was a little devastated when he had to retire because he was our Derek Jeter, right? Mm-hmm. He was the homegrown guy that was going to be the savior, and really nice, awesome guy. So spinal stenosis, though. What is spinal stenosis? The best way I describe spinal stenosis is your spinal cord and the spinal bones around it are like a tube. And the stenosis is really that tube starting to close up, kind of building calcification like your plumbing does. Mm-hmm. And as that tube starts to close up, those nerves have nowhere to go. They still got to live in that environment. Well, as that starts to happen, the nerves also have blood supply to them. And the blood supply starts to get pinched off a little bit, and the nerves themselves start to get pinched. So you start to develop these symptoms of heaviness or numbness in the feet. The symptoms of spinal stenosis are much different than the symptoms of what we were talking about before with disc herniations and sciatica. It's more of a heaviness. It's more of a not feeling where you are in space, or you feel like your legs are going to give out on you when you're walking a long distance, something along those lines. We treat that very well. Basically, we can, first of all, if it's mechanical totally in nature, which isn't often in young people, you will need some kind of minimally invasive surgery to open that up. Sometimes if it's multiple levels, which it can be as we age, you can have multiple level stenosis, you may need a surgery to really do a laminectomy, we call it, take the pressure off all those nerves. A lot of it, though, can be chemotaxis, which is like that jalapeno sauce I talked about, where you can do an epidural even for that can clear out some of that inflammation and give those nerves a little more breathing room, make them feel a little more healthy for some time to get you through your activity and get you through living your life.
Again, here with Dr. Anthony Giuffrida, board certified and fellowship trained in interventional spine and sports medicine. His practice is at the Cantor Spine Center at the Paley Orthopedic and Spine Institute, and it is dedicated to the treatment of spine and sports-related pain. So now over to the NFL, where Chargers wide receiver Mike Williams missed the team's 31-30 playoff loss to the Jaguars because of a fracture in his back suffered in the Week 18 game. And again, another one of your specialties is the spinal compression fracture. Again, what is a spinal compression fracture, and is there a non-surgical treatment for this type of condition?
Yeah, so spinal compression fractures in a young person after an injury, a fall, or in this case, usually a helmet to the back, will usually heal on their own, just with a lot of rest, just like any other fracture in the body. The problem with spinal compression fractures is if they're pushing on any of the important stuff there, any nerves or anything that can really cause a problem, because some of those important nerves run through our spinal cord, even in the lumbar spine, that can cause problem with our going to the bathroom, problems with us walking. If that's an issue, then that's an emergent surgery that needs to be fixed right away. If you don't have any of those issues, then first thing we try to do is let it heal. There's different parts of your back you can break as well. As we age, we're more likely to break what's called the vertebral body, or the big part of the bone that we've seen before in the spine. If that happens, then there's a procedure out there called a kyphoplasty, where we can actually fix that fracture. We can put a balloon through a needle, put a little needle into your spine, into the bone, blow up a balloon, and we put some bone cement in there, and it shores up the fracture and gives you a little bit of that height back from the compression, if you think about it. That helps threefold. Helps, one, fixes the fracture. Two, gets rid of the pain. And three, gives you some of that height back that you don't want to lose, because you don't want to have something called kyphosis, where you're bending forward and forward and forward as we age. That'll hurt things like your lung capacity and also just your ability to move around when you're bending forward. So for me, kyphoplasty is actually the most fun procedure that I do because patients do so well from it. They come in with 10 out of 10 pain. We fix their fracture. They walk out with 0 out of 10 pain.
Wow.
And they do really, really well. But for young people with fractures, as long as they don't have any major spinal cord injury or nerve compression, usually you wait and it'll heal on its own. The hard part with athletes is when do you let them go back to play? And that can be very controversial. We see it a lot in our high school athletes, our college athletes, where I kind of look at them and say, hey, man, this is your spine. I know you're trying to go D1 or I know you're trying to make it to the league. You really have to be careful because what you don't want to do is keep breaking it. Break it again and go back before it's healed. And it's really hard in the spine. Listen, if someone broke their leg, no one would say anything. You'd say, I got to wait till the leg heals. For some reason, the spine, a lot of people don't. They say, it's painful, but I can still move and groove. There's a lot of important things there that if you get a second injury in the same spot, you can really cause some problems. So you got to be smart about it. See your doc, see what they're saying. Get imaging over a few months and see how it's healing.
A couple more things here with Dr. Anthony Giuffrida from the Cantor Spine Center at the Paley Orthopedic and Spine Institute. And another big name NFL player whose injury falls under your expertise is New Orleans Saints running back Alvin Kamara, who had a sacroiliac or SI joint flare up, and it just needed some rest and a little injection, but nothing serious, and Kamara never missed a game for the injury. Dr. Giuffrida, can you explain what the SI joint injury is, and again, how you provide treatment for that?
Yeah, so the SI joint is a very important joint in the body. It's what attaches the spine to our pelvis, or basically attaches the spine to our legs. It's what lets us operate the way we do as humans. The interaction with the SI joint is interesting. It's not like a joint like our knee or our shoulder or our hip that has a lot of movement. It actually has a lot of micro movement, but it's very important movement. It's what allows us to twist and move and bend without being very stiff in the pelvic area. What can happen there, though, any joint that can move can develop inflammation, especially if there's trauma. A lot of running backs get hit in the back, get hit right on that SI joint. Things can flare up very, very quickly. Usually it's a flare-up from trauma, inflammation. SI joint injections do wonders. It's almost to the point where the patient comes in, 8 out of 10 pain, you do the injection, it calms it down. It kind of like you have a fire, it puts out the fire right away. SI joint pathology gets more prevalent as we age as well. A little less motion we have in those joints, so they start to kind of seize up. I always tell people motion is lotion, right? You need to have that oil in that joint to keep it moving. As we get a little sedentary, those joints start to seize up and actually can cause a lot of what people think are hip pain, actually. Because your hip pain is usually more in the front, in the anterior part. SI joint pain is more in the buttocks region there in the back. Once again, we can do injections in those patients. We also have the option of doing PRP injections in those area. But sometimes what we have to do is stabilize that joint. And there are minimally invasive ways to stabilize that joint as well with something called an SI joint infusion. But in young people, injections do very, very well. Clean out that inflammation, shore up that area, and usually they can get back to playing within a week.
Dr. Giuffrida, you mentioned a PRP injection, which is what Josh Allen received in his elbow. What is the PRP injection, and is that something that you would offer for a patient dealing with a back or a spine issue?
Yeah, so PRP injections have been around for a while now, and really the way I explain it to my patients are, you get a cut in your arm, and it heals. You don't do anything, right? It heals. Why does it heal? It's because of properties that are in our blood, properties that with the platelets that the platelets give off as well. And we don't have to get real molecular about this, but it's the important stuff in our blood. It's not the red cells that heal it. The white cells help out a little bit, but honestly, it's not them at all. It's really what the platelets bring to the party that help heal it. The problem is in something like Josh Allen's elbow or my elbow or your elbow and a lot of other tendons and ligaments around the body, there's not a lot of blood supply. So it can't really heal itself on its own. We kept getting these micro tears, and it starts causing inflammation and pain. You can do a steroid injection, but honestly, a steroid injection in a lot of these areas can actually weaken those ligaments a little bit. So what we do is PRP injections, and it basically takes all that good healing properties from our blood, inject it to an area that doesn't have a lot of blood supply, and gives it a chance to heal. And it really does wonders, especially for elbow injuries or bursitis, in the hip, in the knee. I also like it in small joints, shoulder joint, knee joint, the SI joint, as we talked before. It really helps decrease the inflammation and heal that area a little bit faster, especially in young patients. It works very well because think about all the good healing properties that young people have in their blood. Why not use that in areas that just don't have the blood supply that need it?
Wrapping things up here on ESPN West Palm tonight with Dr. Anthony Giuffrida, who is board certified and fellowship trained in interventional spine and sports medicine. And Dr. Giuffrida, we've covered a ton of issues from herniated discs to spinal stenosis, spinal fractures, nerve impingements, and more. Doctor, what is the testing needed to figure out which of these conditions that a patient may be dealing with? You know, can you make a diagnosis these days just from a standard MRI?
I love this question because before I went into interventional spine, my specialty was physical medicine and rehab, so I'm a physiatrist. Mm-hmm. So the number one thing, and I teach fellows and I teach residents and I teach students, the number one thing you have to do is listen to your patient. So it's called getting a history. So we get the history of what's going on. That is going to point you in the right direction. Then the second thing you need to do is you need to put your hands on the patient and do a really good physical exam. Find out where some weakness is, find out if there's some sensory loss, check their reflexes, see them walk, have them walk in different directions, have them do tandem gait. That's more important than anything. Then you get the imaging, the MRI or an ultrasound if we're looking at a tendon, and really see what's going on. That whole picture together will give you the answer. You know, this day in medicine where we're not able to see the patient for as much time, it's really gotten rid of the physical exam, and that is the most important part. The MRI just guides you further down the path that you should already be on. Now, that being said, yes, MRIs are very, very good. I tell patients it's like cheating. It gives me the answer. But you have to have an idea of what's going on before you get that imaging, before you get that MRI. And all those things together should lead you to a proper diagnosis. This is what I say. I do a lot of injections in different areas. I can do SI joint, facet joint, spinal stenosis injections, sciatica injections. All those areas are within inches of each other. If I do an injection and it doesn't work, maybe it's not because the injection isn't going to help that issue. Maybe it's the wrong issue that we're treating, right? So you really want to be in the right diagnosis, going down the right path before you put the patient up for a procedure of some sort.
Dr. Giuffrida, we've talked about the back, we've talked about elbow care. What other types of interventional spine and pain management do you offer?
Great question. So I think it's a very exciting time to be in the interventional spine space. Things are getting more and more minimally invasive, which is right in our wheelhouse because we work under the fluoroscope or the x-ray machine where we don't have to cut people open to fix things. So a lot of what we're focusing on now is the lumbar spinal muscles. There's a new procedure out called the Reactivate procedure where we could actually stimulate those muscles that are starting to weaken. And the reason those weaken is because of any ailment in the back. You kind of shut off those muscles because it hurts to move. We all have those friends or maybe ourselves that can't move in our lower back because it hurts too much. So that's where I'm excited is that we're not only trying to fix problems with hardware or with epidurals or with PRP, we're trying to prevent problems from happening. I'm a big component of sending people to physical therapy. Mm-hmm. Before you do any of these procedures we're talking about, you should always do some physical therapy. Well, this is an internal physical therapist that actually stimulates your muscles in the lower back and helps you stabilize your lumbar spine. And if you have a good, stable lumbar spine, guess what? None of these problems really happen. You know, spinal fracture from getting hit by a bus, which is basically what happens to these guys coming across the middle. You can't avoid that. But the stronger your lumbar spine muscles are, the less likely chance you're going to have a degenerative disease or degenerative issues. So that's some of the new stuff coming in the space. And also just how minimally invasive everything's getting. I think 5 years ago, I don't think we'd believe where we're at now. And I think 5 years from now, what we'll be able to do, full open big surgery might be a thing of the past in 5-10 years. And it's good for the patient because the less harm we do when we're fixing a problem, the better off the patient is.
Dr. Giuffrida, this has been awesome stuff for me personally, as again, somebody who's had plenty of back problems, but also I'm sure a lot of our listeners here in Palm Beach County and the Treasure Coast. But again, before you go, mentioned that you were a relief pitcher in baseball. So I got to ask, what are your feelings on the pitch clock and the shift in the major leagues this season?
I actually like the pitch clock. I always was a very quick worker. I think it's an advantage to the pitcher. I always hated when batters stood outside the box. I'm like, all right, let's go. Because in my mindset, for me as the pitcher, I'm the best and you got to try to beat me. I'm coming at you 100%. And letting them sit there and wait kind of gave them an advantage. So as a pitcher, I love the pitch clock. I say, giddy up, let's go. And also as a fielder, I think they're going to love the pitch clock too because you're not sitting there around, waiting in the hot sun. The shift, I kind of wish people would have adjusted.
Totally.
Hit the ball the other way. Yeah. Their shift goes away. Look at I'm a big Mets fan, like I said. Jeff McNeil. They didn't shift against Jeff McNeil. If you shift against Jeff McNeil, he'll hit 400 through the left side.
Sure.
Think about Tony Gwynn. I mean, Tony Gwynn would have hit 600 if people shifted against him. So I wish the players could have figured it out, but I understand, unfortunately, when I was taught to hit, it was not the drop lift that they're teaching now. People are trying to hit the ball out of the ballpark, and it's easier to do that when you pull the ball. So I guess if we're not going to go the other way, I'd rather not see this shift. You hate to see a guy rip one to the right side, and it's a double play every time for a lefty. But I love the pitch clock. Don't love the shift. Like seeing more stolen bases with those new rules. But yeah, it's fun to see baseball evolving. I heard just today that highest attendance for the first 2 months that they've had in 6 to 10 years, which is good because I was afraid baseball was going to kind of die off with attendance, and now it seems to be coming back. So I'm happy about that.
Well, Dr. Giuffrida, I'll let you go. But again, thank you so much for your time. This has been hugely helpful for, I'm sure, so many people. Hugely informative. Again, thanks so much, and I'm looking forward to talking to you again down the road.
Awesome. Thank you very much.
Once again, that was Dr. Anthony Giuffrida from the Cantor Spine Center at the Paley Orthopedic and Spine Institute in West Palm Beach and Fort Lauderdale. For more information on Dr. Giuffrida, visit paleyinstitute.org. That is PALEY institute.org, or call the Paley Orthopedic and Spine Institute at 561-446-0645.